Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking. Welcome, everyone. I'm your host, Todd Searls, Vice President of Business Development at Caravan Health, and this is Healthcare by the Numbers, a podcast that explores the numbers driving change throughout our industry. To learn more about Caravan Health, this podcast, and to check out episodes of the show, visit caravanhealth.com. And be sure to sign up for our newsletter to be notified of future episodes. You can also visit us on our program page on Healthcare Now Radio and follow us on Twitter, LinkedIn, and Facebook under our username at Caravan Health. Well, today I'm accompanied by my colleague and our Chief Medical Officer at Caravan Health, Dr. Ashok Roy. And together we are very pleased to be speaking with Shawn Rhodes, Director of Clinical Integration at MedCenter Health, who's also a client of ours inside of Caravan. For those of you who may not be familiar with either Dr. Roy or Shawn, Dr. Roy has over 20 years of experience in population health, health consulting, healthcare administration within healthcare systems, payers, outpatient clinics, and governmental military organizations. He has experience in analyzing value-based opportunities amongst healthcare systems, as well as designing clinical programs to help identify opportunities and measure progress. His passion really is around using data to create patient-specific clinical experiences, leading to improved patient outcomes and satisfaction, while decreasing unnecessary utilization and healthcare costs. And for Shawn, more than 20 years of operations, consulting, and development experience in healthcare industries, with a wealth of experience in technology, teamwork, leadership, proven skills as an innovator, as well as an agent of change. Shawn brings a talent for breaking down silos, making complex cross-functional projects successful, and is really driven by the opportunity to add measurable value to the organizations that he's a part of. I want to welcome both of you to the podcast. Thank you so much for being here.
Thank you.
Thank you, Todd. Appreciate it.
Now, normally we would jump straight into our numbers segment that kind of helps outline and define where we go. But today I've got two individuals who have, I think, quite a bit of experience, both from the provider side and then on the administrative and organizational side. And so I just wanted to jump right in. I want to get on the record a statement from each of you. Do you believe that from your perspective, from your experience, that the current state of value-based contracting, value-based care, in particular with respect to Medicare, since that tends to be Caravan Health's focus, is where we really need to be as a country, either or from both the provider or the healthcare executive point of view? And Dr. Roy, I'm going to put you on the spot first.
Okay. Since we belong to a population healthcare company, I mean, I am passionate about it, and I think it is the direction to go forward with. The problem is, even though a lot of hospitals do participate in, pay for performance, it's still dominated by a fee-for-service world. So the only way, even though I believe this is the way to go, I think once we get enough adoption, right, a certain tipping point, and the results really show it, there'll be further adoption. But just getting to that threshold in which people really change their behavior, because most of their panel, most of their reimbursement does come from performance measures, is going to be the tough barrier. But again, I think it'll be much easier once we reach that threshold.
Shawn?
I would agree with Dr. Roy on all counts. The part I would add to that is, healthcare needs to change. I think value-based care is kind of driving the direction. Is it going to be what we do in the end exactly the way it is now? I don't think it will be. I think it will continue to adopt and change, and especially as Dr. Roy pointed out, as we get more adoption and change that mindset, I think we'll really start to shift our healthcare system from a sick care focused to a more healthcare proactive instead of reactive processes. So I absolutely agree. We're heading in the right direction. We've got a lot of work to do ahead of us, but bit by bit, day by day, I think we're making a difference.
Well, I think having two people who have had such exposure to this, it does, of course, I'm passionate about this, especially in rural areas, that I've spent a considerable portion of my career, and I can see the impact that it's had not only on engaging patients who, heretofore have been perhaps a bit stubborn about improving their life, taking advantage of healthcare more as a reactive as opposed to a proactive partner. I'm seeing the changes. And so I think, I'm really looking forward to our discussion, because the lessons that come out of these experiences that we share, I think will help clarify for others who are perhaps listening in today, kind of the progress that's been made, as well as the challenges that are still out there. But I'm particularly interested in how we motivate the physicians and the administrations of their healthcare organization to kind of align mission and message, such that the contracts are equitable for both parties. And so I'll definitely want to dig into that. I definitely want to kind of address it as well, outside of Medicare, other commercial programs and the metrics, and are they aligning, or are they actually being more of a distraction? Because if you go into one, you have to focus on one set, as opposed to if you go into commercial or MA or Medicaid, you're suddenly torn and having to focus on something completely different, and it's not synergistic. Where your thoughts are on that. And I think, at the end of the day, that's just to help us keep track of how we're doing. So the metrics, which leads us into our normal number segments. In this podcast, we like to bring in some current numbers, which do shape healthcare policy. And so for today, I thought we'd spotlight how providers are actually giving up independent practice. We've all heard it. We've seen the news articles. We've gone to HIMSS. We've seen NACOs talk about it, and other groups and associations, that in exchange for receiving more technical, administrative, and perhaps even clinical support from hospitals or larger multi-specialty groups, independent PCPs are actually giving up their independence so that they can meet these new quality and performance thresholds that are required under these value-based agreements. We know burnout is real. It is absolutely dynamically shifting, the who's in charge paradigm. And so with that as a backdrop, these are the numbers that we pulled for this episode. So the employment shifts have been happening for years. I think that's safe to say. But in recent years, 2019, a study from the American Medical Association showed that for the very first time, more physicians were employed by a hospital or a hospital-owned practice than were independent. Numbers are trending this way even for primary care, specialties such as internal med, family med. The same AMA study showed that for the internists, 46.9% owned their practice, while 46.8% were employed, and 6.3% were independent contractors. So once again, kind of falling and straddling both of that. The numbers show that more family doctors are employed compared to independent. 37.5% own their own practice, 57.4% are employed, and 5.1% are independent contractors. So why is this occurring? I think if we've tracked the industry accurately, a recent study from the Federal Agency for Healthcare Research and Quality shows nearly half of primary care physicians report signs of burnout because of time pressure and working conditions. I've worked side by side with physicians who, I've had to help them troubleshoot their EHR at 8 p.m. while they're trying to squeeze out the last few minutes of family time with their kids. And they can't do both, right? I mean, working from 7 a.m. or 6 a.m. through 9 p.m., it's just untenable. In the same study from the Agency for Healthcare Research, more than half of these physicians were feeling time pressures when even conducting just basic physical examinations. Nearly a third of them felt that they needed much more time than was allotted for this patient care function, which, as it relates to value-based care, this is all about what hopefully team-based care approaches will help ease some of this burden. And then finally, nearly 25% said they needed at least 50% more time for follow-up appointments, which is pretty dramatic, right? That's a huge increase in, the amount of time that they would like to spend with their patients, but there are only so many hours in the day and so many months in a year. So to me, the numbers seem pretty clear. Physicians need more time to do all the things they are being asked to do, or they'll need more support to help them do those things. And for a lot of independent physicians, they just can't do it on their own. They can't afford to bring in perhaps that outside support, and they're just completely burning out in the process. So, Dr. Roy, Shawn, what do you think? I mean, do you concur with the studies? Is value-based care going to help, or is it, not so simple, not so black and white? Is value-based care just one part of an ever-growing, complex American healthcare system puzzle?
So I could do some thoughts on the physician burnout. So it really is not a fee-for-service versus value-based care issue. It really is utilizing your team well, and it helps in both areas. So where we've seen this be successful in a fee-for-service world is by hiring more staff, leveraging your team, you're able to see many more patients. You're able to have scribes that write your notes. If you teach proper, pending order, pre-visit planning, that gets all done. So you're able to leverage more of the time you would spend documenting, doing other things with the patient. And so that just becomes a well-oiled machine, but it still follows the principle of throughput. I need to see X number of people in a day in order to achieve this money to support the staff that's need to run this machine. And even though we think like, that's great, that's awesome, those same, benefits, or those same benefits of using the team-based care, we could also find in the pay for performance. So the difference is in value-based contracts, the people who need 40 minutes should get 40 minutes. Now, what we're hoping that if we do this well and we're able to manage the population better, we will get reimbursed more, which we can invest more into our team. But the fundamentals of making sure my team works to the top of their license, seeing, it's maybe not hiring scribes, but making sure that protocols are in, that standing orders are in, it's the same thing. So the physician burnout, I think, affects both worlds. And people tend to, in independent practice, they retire thinking, I'm going to go work in a hospital. And I always call it the Fred Flintstone thing, where at 5 o'clock, they're done. That's what they're giving up, the independence, in order to get the stability. And what they find a lot of times is, maybe for the first 3-4 years, it's fine. But then they get the pressure of, you need to see X number of patients per month or per year. And so the stress becomes different of seeing a patient every 10 minutes, every 5 minutes. And then that's not congruent with value-based care. But this quick, easy thing of, hey, I'm going to now be employed and things are going to get better, it's not as rosy as they think.
On the administrative side, one of the things that we see with burnout is, in fee-for-service, the main incentive is speed. So the faster you see patients, the more you see, the more incentive is there. Some of the burnout that we're seeing from our providers are, we're trying to take that and change it into a value-based care model. But in relationship to what Dr. Roy was talking about, we're not working with the workflows. We're not changing the team-based approach and moving to the team-based approach. It all gets put on the physician. And everybody thinks it's the physician doing all of these things and taking care of all these things. And while, we kind of look at it as the physician is somewhat the conductor of the orchestra, but the orchestra is made up of all those people working to the top of their license. And if you're trying to make a change from fee-for-service to value-based care, you're really turning it up on its end and trying to shove a square peg in a round hole. You've got to really step back and take the time to look at your workflows and your practices and build a collaborative approach to patient care in doing that. Because if we don't start doing things like that, we're going to continue to see physician burnout, and we're going to see staff burnout because the physician gets frustrated and those things start to happen. That just kind of builds throughout the practice and vice versa.
Shawn, I wanted to give you an opportunity, to kind of perhaps elaborate on that a little bit more and about your health system and what you've done to communicate exactly what you just said to your clinical teams about how we have to start transitioning it. Do you want to give us a little bit of background, a little bit of color as to the medical center at Bowling Green? Yeah,
so the medical center at Bowling Green we're a 6-hospital system. The medical center is the whole owner of MedCenter Health Partners, which is a clinically integrated network of employed and independent providers. With that network, we then in turn have eight different value-based programs that we participate in, one of those 8 being the ACO. And so we're working with MedCenter Health on the physician side, not so much the hospital side, to transition that. The difficulty for us has been, when you're a hospital system, the hospital is the focus. It's the biggest part of what you do. It's the driver, if you will. And being in a fee-for-service world, it's hard for a fee-for-service hospital to really shift gears and look at what value-based care is going to look right down the road. You've got to take some time to make some investment up front to get the gains down the road. It's no longer you see X amount of patients, you're going to get X amount of dollars in revenue. It's you need to see X amount of patients, you need to do X amount of care gap closure, you need to do X amount of annual wellness visits, and focus in on those things to start to change the system. So, trying to make that investment, and it's where we struggled, is, we have to do that investment in small increments, and that small increments makes it even harder to change and more complex, because you're only changing a little bit at a time instead of trying to redesign the whole thing. So it's been a balancing act for us. We're making progress, but we are struggling at the same time.
Do you find that physicians are at the table for every decision, or at least a champion, or because of, like Dr. Roy, you had mentioned, right, we have moved within our fee-for-service world, we just don't have time to pull them out of a clinic and get them as actively integrated as we would like. Has that been a challenge you've seen?
It has. As I said, our network, we have independent and employed, and it gives us an interesting viewpoint, because you can see the independents that really embrace value-based care and that have really gone after it and really done very, very well with it, versus the employed. A lot of it tries to fall to the physician, but it really can't. It more falls to how we're going to support the physician in their employed environment, and how you put those resources forward in helping that. It's a sense of or a bit of control that the independents have that the employed physicians do not.
So is that something, and Dr. Roy, I would perhaps kick this one over to you, is that in order to help those physicians, perhaps in your case, like you were talking about, Shawn, it really more is a discussion with the employed doctors, that contracting, when you're now wanting to look at your, the actual employee agreement that you're signing with the physician to perform services for you, do you find it's talking about mainly the quality metrics and parameters, the money that could be earned and passed on to them as incentives? Or is there a component where they then say, no, I totally get the KPIs and the metrics that I have to meet, but I also want this to support me. I need a scribe. I need this or that or another. Do you find the physicians then coming back and asking for extra support as part of, if they're going to sign one of these amended contracts to participate in these programs?
So the extra support, there's every physician that wants extra support, right?
Sure.
Extra MA, extra scribe, extra front desk people. That's all fine and dandy. Where I've seen the independent practices do this better is almost like treating them like small businesses within a small business. So they're like, great, I hear you. You want an extra MA, we could give it to you, right? But you need to cover the costs for the extra MA. So we're assuming that with the extra MA, you'll be able to see more patients. And in that way, boom, you could cover the cost. So it's almost like taking a mini loan, right, against the organization. And so again, that's the fee-for-service world. Same thing kind of applies for your value-based care. But instead of knowing your incremental revenue by how many patients you've seen, it's the hope that if you do things well, you'll have the shared savings to cover the cost. It's a little bit of a gamble. And I think that's what freaks out people. Because, when you see patients, by the end of the day how much gross revenue you're getting. With value-based care, you have to wait, and then you're waiting 18 months, right, from when you start. And that's a scary thought, because that's people's livelihoods.
You mentioned the word hope. and we've used that term too. We hope we're going to get this. And someone once said, well, hope is not a method. And so that's the crux of it. That's where we're trying to, if we do this, we get that. And it's still unsure. And we've had those conversations with doctors to move their contracts from worked RVUs to quality indicators. And that's where they went is, well, we can do these things, but how am I going to have time on everything else that I have? We need more people to help do that.
Now we have a mix, obviously, of your urban fee-for-service clinic versus, say, a rural health clinic that bills under, UB4s and don't get perhaps the same level of reimbursement as fee-for-service clinics. So how does that play into these recruiting physicians for ACOs and other value-based contracts? Is it easier or harder? Or, I have my own opinions from having worked in rural for a long time, but I thought I'd ask both of you. I mean, is there a different way to recruit those providers into those facilities with the ACO or other value-based contracts as a carrot or a stick?
But I'll go first since Dr. Roy's gone first.
I was going to say, Dr. Rhodes, go ahead.
I firmly believe in our organization kind of follows, you're never going to be successful with a stick. You've got to put a carrot out there. It does take a lot of effort because I would say in Bowling Green, Kentucky, a lot of our providers are in rural areas. We have several RHCs that operate within our network, and it is difficult to recruit in those areas. Now, some successes we've seen are being able to recruit early on, when they're in high school or when they're in college and they're from that area. So, you can kind of bring them back, and sometimes that works well, but it is a challenge, because the primary care, especially primary care doctors, are so in demand right now that it's difficult to get somebody that wants to settle down into a rural area to do that.
Sure.
Yeah, no, it is tough. And then the problem is in the urban areas, your turnaround rate on your primary care docs in those big medical centers is 20-30%.
Wow.
It's really high because, again, their incentive, there's so much opportunity that if they don't like someplace, they go somewhere else. But actually the rural docs, especially the family medicine docs, they have the right type of skill set to make value-based care successful. So I'm going to give my own personal example. So I worked internal medicine clinics, fee-for-service world. Even doing a pelvic exam, it took so much time that you're kind of like, do I really want to do it? Or do I turf that to the OB doc to do, right?
Right.
Your diabetic patients, it's like, great, I'm going to write for podiatry. So you're almost like feeding a system. By giving all these referrals out, I'm able to save time. It doesn't cost me anything. I get no negative benefit. I feed the system. And guess what? In my mind, everyone's happy, right? But is it best for the patient? Probably not. You read about rural medicine where these docs, not only do they practice at the top of their license, sometimes they practice above their license, right? Yeah. But they do these things anyway, because guess what? The nearest ENT doc's 150 miles away. So for them, making the selling point that you're primed for success, you're doing this work anyway, why not get rewarded? But again, they need guarantees, right? Because it's too much to bank on hope. So I think coming up with a structure where there are floors is important. And so it requires the organization to take even further risk so that the risk on the individual providers or clinics are less. So how do we do that well? I'm not a financial expert, but there's ways where we can mitigate risk to get more buy-in. And I think it will be more successful in the rural areas, actually.
It's interesting. I would agree in the fact that, most of the rural physicians who I've worked with they were attracted to rural areas for a reason, right? They like the idea of meeting their community and having patients for 20, 30 years. They're also invested in that community, right? They feel like they are an important member of it, and anything that is done in the four walls of the clinic or the hospital, it reflects on them personally, and they are invested in the growth of that. it is not necessarily to say I live in Lincoln, Nebraska, which most people would not say is a big urban city compared to New York City or Kansas City, but it's a big city here for the Midwest. And even my doc is invested in it, right? So you do still find some individuals who are that way no matter what. But I think it does bear the question, the individuals who are going into primary care today, is the population health dynamic and the team-based care approach, is that what's being taught in medical school today, such that when they come out, this is old hat to them, or are we still changing that paradigm?
I am 20 years out of medical school, so you know my age.
Yeah.
That was definitely not taught. It's taught, like, you're taught to be the doctor that could handle like the 1% of cases, right? I mean, that's how we're taught. So we have the knowledge. I mean, they always use the example of the Chinese foot doctor, whether it's made up or not. You could train people to a level after 1 year to probably handle 90% of all ailments out there, right? But in medical school, they train to deal with that 90% that you may never see in your life. I mean, there's so many diseases I've never seen a patient with this disease, right? And you always see those TV films that they know it off the top of their heads. I mean, that's how we're trained. But it's not into value-based care or how it's structured. I mean, there's surveys on financial literacy for medical students. They just don't know. And it's not made part of the curriculum. It's just not a priority right now.
Sure.
So I don't know. Yeah, you're probably, you went to med school probably, later than I did. So maybe things change.
But I can tell you that, as MedCenter Health, it has a partnership with the University of Kentucky. And the University of Kentucky is in Lexington, which is about 3 hours from Bowling Green. But we now have a medical school campus here in Bowling Green. It's a very small campus, but nonetheless a medical school. We've had, this is our third year of that school. And I can tell you, we have our residents, really involved with a lot of different pieces and parts of MedCenter Health. But we are, in the school, is not really pursuing that value-based care involvement. Now, I think as we see our practices change, it's going to be inherent that as they learn, they will. But most medical schools, in our experience, are not set up to do that yet.
Interesting. And therefore, then it falls on you to explain the ins, the outs, the metrics that you need them to achieve, which may be slightly different than what they were expecting. And, that then obviously could influence whether or not they want to join or, their satisfaction once they get into actual practice. So would you say overall, has this shift towards population health, Shawn, been beneficial for your organization as you look, your patients, once they get in, they understand what's being done? Do you find that it's starting to be conversations that are had more frequently and better received, or is it still a long slog?
It's a little bit of both. We're starting to see bits and pieces where we are making a big difference in individual lives. We're starting to see, from a staff perspective, especially really catching on to what we're doing and what value-based care can do. And we've got some physicians that are just, and I say sometimes more so the independents than the employed, are really passionate about it. They see the value it brings to their patients. They see the engagement they get with their patients and the relationships they build. And physicians want to focus, in my experience, physicians want to focus on, taking care of people, working with people. The administrative stuff and all that, that's not why they got into medicine. Now, you've got some physicians that are really good at it, just have the business acumen. It comes natural to them. And when you have those types of physicians, they do well in the independent. And then when you have the ones that they do well in employed. But we've got to make sure that our staff are just as excited about it to get the physicians excited about it, and vice versa. So it's going to continue to be a struggle for a while, I think. It's not something that's going to happen overnight. I think as we're speeding up, or I say we, as the healthcare system is speeding up, moving more towards risk, we're actually getting payers that we have programs with now that are reaching out to us, wanting us to take our value-based agreements to a risk model or two-sided risk model. And we're a little apprehensive of that because how do we share that risk and how does that play out? What are the potentials? And we kind of go on, we hope it's a good thing, but that hope is not a method. So trying to figure out what that method is and moving forward.
Well, look at nothing other than the pandemic, right? It's hard to, even if you've got the best population health services, something could happen that just, whatever you're doing doesn't necessarily touch a pandemic. For instance, patients not showing up, they're too scared, therefore their conditions deteriorate. You've done everything you can to engage them virtually or otherwise. There could be technology limits. So it makes perfect sense to me that groups would be risk adverse. And it's even more important today that payers across the board understand that physicians want to partner, but you can't bankrupt them in case of the unforeseen. And hopefully we'll see a shift where risk sharing is not so onerous that it could put companies out of business per se. Or, it also speaks to the model, right? You have to partner with other organizations who are just as committed as you so that you can share that risk across those organizations. And your risk pool gets bigger, no different than a payer. Okay. And I think that's what ACOs are doing. That's what we at Caravan are trying to do. So if one community does have a bad year, they don't suffer because they're part of the larger group. But it's still, when you sit down in front of your boards, it's still a conversation that has to be had about checks that may have to be written if you don't perform according to the scale that's set for you across the payer. Yep. How, and I'll last question, and then we'll kind of run into wrap-ups, but how have those community conversations gone for you and your organization, Shawn? Has, your board members been actively involved in this, or is this just, perhaps something that is still in the works of kind of figuring out before they really get the nitty-gritty details?
It's a little bit of both. We've started conversations with, especially our clinically negative network board, in what risk is coming, especially with the ACO. We're going to start in that risk agreement in 2023. So we've started that conversation just to kind of work through, all right, how do we take risk? How do we share risk as a network? And what does it mean to take risk? And really trying to sit down with physicians and have that conversation about, this is coming. The change is going to happen. It has to happen. Healthcare system is terribly broken the way it is. Costs are getting out of control. And so we've got to do something different. This is what we have in front of us. It's a great opportunity for us and our patients. And so having those conversations are going to take some time, but we've at least started.
Excellent. Well, I know it has been a pleasure for me to have both of you on to kind of address some of this kind of, the uncertainty about how to approach physicians, to engage them in, say, a meaningful contract that's beneficial for both parties. Sometimes it's based on where you live. It's based on the provider. It's based on, are they a specialist or a family medicine doctor? What are their wants and needs and concerns with such an arrangement? But I think in the greater scheme of things, Shawn, you just said it wonderfully well. I think risk is here. These arrangements are ubiquitous across all payers now, right? The way we used to do business is kind of over. And so how can the education get out there? How can people thrive in these environments? That's what we're focused on. But I want to ask final thoughts. What haven't we brought up that you guys have been kind of thinking about why we've been on the call? Dr. Roy?
I mean, the one thing, the $1 million question is, what do you do with specialists, right? In your ACOs, they tend up making up 40, 50, 60% of your ACO. And I mean, the end game, technically, is that if everyone works to license, you don't refer out as much, right? Yep. And that goes against exactly their model, where they're almost like they're like royalty in the hospital, right? And so having that conversation, getting them engaged early on, is a challenge. And I don't think we have a right formula of how it would work well. I mean, we're not talking about the surgeons per se, or but mainly the medicine, internal medicine, endocrinology, right? That's tough. Yeah. And but it's something we still need to figure out.
I would agree. Our focus right now is primary care and working with those primary care physicians, and I would give a takeaway from all of this. The one thing I would tell folks is you have to have a collaborative approach with the physicians. You can't take this to them and tell them this is what you've got to do. Especially, and I'm speaking more so from the employed standpoint, you've got to sit down and have a conversation and say, here's what we're up against. Here's what it's going to look like. Here's what the payers are coming at us with. And a lot of times, and I think in our previous conversation, Dr. Roy said, the payers will work with you. You just got to have the conversation with them. But I would tell you, have those conversations with your providers, have them at the table. If you do, you'll see a lot more success than if you come to them after the fact and say, this is what we've got to do, or this is what we just signed up to do.
Yeah, I think we learned that as an organization several years ago when we suddenly started polling our medical champions, the physician champions, asking them how many of them knew were going into an ACO, and you get 15% of the hands raised. And now, fortunately, that's the vast majority of hands that go up, because even on our initial calls with a new client, we're bringing that up. This has to be, transparent to everyone, especially the physicians. I think, old teacher of mine said it best. It's not that people will rebel or that they fear change. They just want you to acknowledge what they're losing. And I think that's more, appropriate in healthcare perhaps than anywhere. As a physician, you're not going to, if I can speak for your profession, Dr. Roy, you're not going to turn away a better care process. You just have to then have people recognize what you thought your job was. Now, where is it going? What control do I have? What control don't I have? Who's supporting me? It's got to be laid out so that it can be understood by everybody. And so, Shawn, I think it's absolutely critical. We start every conversation with full transparency, and hopefully that builds trust and respect. And that's what will ultimately help us succeed with these new programs. Well, again, thank you both so much for joining me today. For our audience, if you'd like to learn more about Dr. Roy and Shawn and their work, you can follow them both on LinkedIn. But I want to thank everyone for listening today. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.